Hello everyone, I'm Carmen Vergara, daughter of Margarita and Juan Vergara, who instilled an incredible work ethic into me and my siblings. I'm also a daughter of Little Village, a community rich in culture, vibrancy, and hard work. I'm a public health nurse and serve as Chief Operating Officer at Esperanza Health Centers. I began my career as a medical assistant at 18 years old, and I worked at a private physician's office in my beloved Little Village. But sadly, this place would turn away patients who did not have insurance or the ability to pay for care. This did not sit well with me, and that experience ignited my interest in healthcare and social justice. Although I didn't quite realize at the time that it was called social justice, it was more just a feeling that I had. At that age, I thought to myself, if I build a career in healthcare, perhaps I can personally take care of these patients who are being turned away. I was maybe a little idealistic, but as I matured, I focused on what I can do and thought about what I can do with a team that had a similar mission. As I got myself some credentials and my career evolved, I looked for opportunities to come back to Little Village to address the wrongs from before, and I finally got my chance at Esperanza, where I'm now the Chief Operating Officer. At Esperanza, we provide care to over 45,000 patients a year, regardless of their ability to pay. But before joining Esperanza, I was a public health student here in Chicago, and during my studies, I was introduced to the health disparity heat maps of Chicago and all of its neighborhoods. A heat map is shaded in a gradient fashion from light to dark, and the worse the health outcome, the darker the shade. Well, over and over, and in class after class, the health disparity heat map always looked exactly the same. The maps would show that certain neighborhoods always had the highest rates of unemployment, heart disease, breast cancer, maternal mortality, obesity, violence, and on and on. I had learned in nursing school that heart disease and diabetes were caused by genetics or eating too much salt, fat, sugar, and not exercising. But public health school broadened the root causes of chronic conditions to poverty and racism and poorly constructed systems. So at the start of the 2020 pandemic, I wondered, what would the heat map look like for COVID-19? Would there even be a heat map? Seemingly, a respiratory droplet virus involving the air that we all breathe would affect everyone equally. But as we all know, it did not. It has disproportionately affected brown and black communities, and once again, the heat map for COVID looks exactly the same as any other health disparity map of Chicago. Now, we all know the tangible reasons why black and brown communities are disproportionately affected. They're essential workers and they live in multi-generational households. But looking back, the very early decision of who could work from home and who was essential instantaneously created the COVID-19 health disparity heat map. That one singular decision began to color the map. And so my guiding question in making decisions has been, how will my decisions or the decisions that I influence impact the color of the map? So back in March of 2020, when there were so many unknowns about COVID-19, we had some decisions to make as well at Esperanza. And we decided that we had to test our communities for COVID. This was not an easy decision. We had to ask our frontline staff to risk daily exposure to a deadly virus, navigate clinical unknowns, and wear uncomfortable PPE for 10 hours a day outside in Chicago's snow, rain, unbearable heat, and gusting winds. Now, fortunately, we had healthcare heroes who bravely offered to test and to take care of our patients. We tested thousands and thousands of patients, and the more we tested, the more cases we found. And our very own decision to test began to impact the color of the COVID heat map as well. There was one particular testing day when we had a positivity rate of 71%. That was 71%. I went to bed that night, but I didn't sleep. There was a painful knot in my stomach, and I was nauseous, I was terrified. I knew from growing up in Little Village that our families work long, hard hours on production lines, and to save some dollars, they tightly ride share in large vans on their way to and from work. They also gather every weekend as a family, and they piece together savings to purchase 3 flat units that house their extended family members. I realized on that very long night that our Latino culture and all its beautiful vibrancy and hard work ethic was going to be self-jeopardizing. So after 10 long and arduous months of testing, the vaccines finally arrived. And the disproportionate race that Esperanza helped uncover made the solid argument for why our community should be prioritized for the COVID vaccine. Immediately, we began to see a heat map of who was being vaccinated in Chicago, and this time we were seeing the opposite effect. Fewer people in brown and black communities were being vaccinated, but we were still early enough in the vaccination distribution stage where we could reverse the inequity that was about to take place. And really the only way to do that was to vaccinate thousands of community members in the hardest hit areas. Operationalizing mass vaccination sites is no easy task. Once you get past the infamous storage requirements and the Herculean efforts not to let one dose go to waste, you get to the real difficult part of making the decision of who gets the vaccine. And it's not as easy as following strict phases. These phases were universally developed for the US population, but they do not reflect our Latino community. In our community, we know that it's the relatively healthy, essential workers between the ages of 45 to 65 who are at most risk for mortality. If we were to follow cookie cutter phases, it would be months before we would get to those who are at the highest risk in our community. One of the first days of launching our mass vaccination site, when supplies were even more limited than now, I was met by an Esperanza patient who accompanied his very healthy 65-year-old friend to his vaccine appointment. With his worn-out socks hat in his hand, he stared down at his feet and quietly told me that he has HIV, COPD, anxiety, and is facing eviction, but he just turned 64 and he knows he's not eligible for the vaccine. He wanted to know if there was any way that we can make an exception for him. There was a decision for me to make here, and he was asking me in front of a very impressionable young staff member who will be a future healthcare leader herself. So I knew this moment and this decision was important. As I began to register him for his vaccination, he got teary-eyed, and so did I. And as I viewed his chart, I noticed that he indeed lived in our community and that he left out 2 additional chronic conditions. The future healthcare leader smiled from ear to ear and escorted him over to get his vaccination. Although it felt great to take care of him, it also felt like no one should have this much power. Nonetheless, the guiding question of how this will impact the color of the map was front and center in my mind. So the question that I leave with you today is, how do your decisions or the decisions that you influence affect the color of the map? When you ask for systemic changes, how will those changes affect the color of the map?